Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we are going to help advance your knowledge on an oral treatment for severe alopecia areata. Our moderator this evening is Dr. Leon Kircik, who's the president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai, adjunct clinical professor of dermatology at Indiana University School of Medicine in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences in Louisville, Kentucky. Our speaker this evening is Jennifer Soung, who is Director of Clinical Research, Southern California Dermatology, and Clinical Professor at Harvard UCLA in Santa Ana, California. We'd like to thank our supporter, Pfizer, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question chat pane on the right-hand side of the screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you 1 to 2 days later. We greatly appreciate it if you would fill it in and send it back to us. And then within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. And now I'd like to pass the floor virtually to Dr. Leon Kircik.
Thank you, Roxanne, and good evening, everyone. Thank you for joining us, our second webinar this week. And I'm very excited to be here tonight. And tonight is an important night. I think we all know it's the election night in the United States. It's one of the most important elections we are having in this country. And I knew that we are competing with the election night, so we had to bring the big guns tonight. But before we go there, I'd like to tell you a little bit about IDEF. So IDEF is a nonprofit organization. Next slide, please, Roxanne. IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And we've been working very hard since the pandemic and during the pandemic to broadcast all over the world. We have been all over globally in Southeast Asia, Europe, North and South America, and Canada. And you can see some of our previous webinars. So before further any ado, I'd like to introduce you our next speaker. However, before that, I'd like you to stay up to date with us, not only on our webinars, but also at LinkedIn, Facebook, as well as Instagram. So tonight, our guest is Dr. Jennifer Soung, Director of Clinical Research at Southern California Dermatology, and she's a clinical professor at Harvard UCLA. And I told you that we're gonna bring our big guns tonight, so stay tuned. And she's gonna tell us about an oral treatment for severe alopecia areata. Welcome, Jennifer. Thank you for being with us tonight. Take it away.
And you can unmute yourself. There you go.
Hi, everyone. Welcome. Thank you for joining me tonight. So we are going to spend the next 30 minutes together. And the topic of tonight's discussion is an oral treatment for severe alopecia areata. As you probably all know, hair loss can be really hard. But what if I told you that there is an opportunity to give patients hope and the possibility of helping a patient live their best life? So in the next 30 minutes, I'm hoping to make it easier and quicker for you when you see your next patient with alopecia areata. As I mentioned, the title is an oral treatment for severe alopecia areata. I've been working on Litfulo and JAK inhibitors for alopecia areata for more than 5 years. So excited to be here tonight to share with you all of my firsthand experience with these medications. Tonight's program is being sponsored and paid for by Pfizer. I am a speaker who is a paid consultant and presenting on behalf of Pfizer. And the information in this program is consistent with FDA guidelines. Okay, give me 1 second. I'm just moving something out of my screen. Okay, doesn't look like it is. Okay, we're going to start with an overview of alopecia areata. We're going to start with a couple polling questions. So I guess okay, great. First one is, what is the mean reported age of alopecia areata onset? I'm going to give you guys about 10 seconds to respond. So the FULO clinical trial program is actually one of the biggest clinical trials ever conducted in alopecia areata patients. So not only did we learn about how patients responded to the medication, but we also learned a lot more about the epidemiology of alopecia areata. So let's take a look. Are we ready for the answer? Okay. So great, you guys are on it. So the most common or the mean reported age of onset is 25 to 36 years old. So tends to be younger patients. Next question. What is the rate of remission for patients with greater than 50% hair loss? So the question is, if you did nothing, some patients come in and they're not ready to move on to systemic therapy, or they don't want any treatment. They're wondering, if I didn't do anything, what would be the chances of me growing my hair back? Give you guys another 10 seconds to put your answers in, then we'll take a look. Okay. Great. I mean, I don't think this is the first time you guys have heard this. So less than 10%. And that is really useful information. And this was collected from the Allegro clinical trials program, where we saw that in the placebo group, patients had less than 10% chance of regrowing their hair. Okay, last and final question. How many patients with alopecia areata tend to progress to totalis or universalis? So to remind you, totalis meaning total complete scalp hair loss. Universalis is total scalp hair loss, including eyebrows and eyelashes. Okay, so let's take a look. So the majority put 1 in 25 patients. So I'm going to show you, so stay tuned. You're going to see the answer on this. So excellent. I get to teach you at least one fun fact tonight. So let's move forward. So often our patients also ask us, will I progress to complete hair loss? And so that's really, let's move on to the slides. Where that question comes from for that last question. So let's see, can I control? Excellent. Okay. So this most scary thing for patients with alopecia areata is that when they start off with 1 or 2 patches is, will this progress or will it kind of regrow spontaneously? So let's review. So 1, in terms of the age onset, we talked about earlier, the mean age of onset is reported to be around 25 to 36 years old. Rates of spontaneous remission for those who have severe hair loss defined by 50% or more of the scalp is less than 10%. So if patients don't do anything, less than 10% chance of spontaneous regrowth. And then that third question is, will I progress in my hair loss? So what we found is that 1 in 4 patients with alopecia areata can develop or go on to develop totalis or universalis. Here you also see some images of the most common types of alopecia areata, the classic circular, round, smooth patches of hair loss. In photo B, you see the ophiasis pattern, which is the band-like pattern that affects the periphery of the scalp. C is slightly more tricky. This is the diffuse type of alopecia areata. So while alopecia areata tends to be a clinical diagnosis, there are situations like this where I will do a biopsy to confirm the diagnosis, especially if I'm considering systemic therapy like FULO. And then D is a patient with totalis. In fact, this patient has scalp involvement with eyebrow and eyelash involvement, so that would be universalis. Okay, so we've learned a lot more about the pathophysiology of alopecia areata because of the discovery of JAK inhibitors. And so this is one of those situations where a serendipitous discovery that JAKs work for alopecia areata allowed us to learn more about the pathophysiology of the disease. And so what we see here, classically, we know that under the microscope on histology, we see that swarm of bees. And in fact, the swarm of bees consists of T cells, specifically CD8 T cells that are attacking to that hair follicle and causing inflammation. These T cells have JAK receptors on their surface, and that's how they communicate messages or signals from cytokines from outside of the cell to inside the cell. So that's where you see those enzymes intracellularly, and downstream they stimulate production of more cytokines or inflammatory proteins that then attack the hair follicle. So you can see that here, that pathway of overproduction of cytokines results in the destruction of the hair follicle that originates from these cytotoxic T cells. Okay, so let's start with Litfulo. So I was super excited. I was part of the clinical trials for 3 years. My patients just recently finished the trial and now transitioned to the on-label or commercially available medication. So let's review the specific indication. Litfulo is actually a kinase inhibitor. And I specifically emphasize that because while it is also working on the JAK enzyme, it works also on a new class of enzymes called TEC enzymes that are involved in autoimmune inflammation. So hence, it was labeled as a kinase inhibitor, which makes it slightly different than all the other JAK inhibitors. It is indicated for this treatment of severe alopecia areata. And I emphasize the word severe because I want you to start thinking about, how do you define severe alopecia areata? I'm going to show you how it was defined in the clinical trials and also get you to think about how you would define it in the real world. It was studied in both adults and adolescents 12 years and older. You'll also see there is a boxed warning here that we'll also talk about. This came from the classic JAK inhibitors. And then you'll also note a small hypersensitive contraindication with regards to hypersensitivity. We will talk about that more when we talk about the most common adverse events. Let's highlight some of the key takeaways for Litfulo. One, it's the first and only FDA-approved treatment for severe alopecia areata in both adults and adolescents as young as 12 years old. I talked about how it's a kinase inhibitor that inhibits 2 enzymes involved in the inflammatory pathway. So not only JAK3, but also TEC kinase family. We're going to take a look at the response of patients to Litfulo, and it's measured by a score called the SALT 20. So severity of alopecia tool less than or equal to 20. In other words, 80% scalp hair regrowth. We'll also take a look at the efficacy and safety profiles of both the adult and adolescent population. And in fact, similar results in efficacy and safety for both populations. The dosing is very easy. It's 1 dose, so it's 1 pill once a day. Okay, so let's see, how does Litfulo work in this inflammatory pathway for alopecia areata? It's a kinase inhibitor that inhibits 2 enzymes, not only JAK3, but also TEC. And so you'll see here that ritlecitinib, the generic name, Litfulo binds to these 2 enzymes to disrupt that pathway of overproduction of inflammatory cytokines. So here you can see it binding to both JAK3 and TEC kinase enzymes, and that reduces the downstream signaling and therefore reduction in gene transcription of key cytokines and reduced cytokine production. Okay. So who do you consider for treatment with Litfulo? We saw that the indication stated severe alopecia. So let's take a look at the type of patients. Here, starting on the left, we see an adolescent patient named Emily. She's 15. She has 90% scalp hair loss, and she was diagnosed during her current episode that's lasted 1.5 years. Then we have Brian, who has a case of rapidly progressing hair loss. So he's 21, he has 50% scalp hair loss involvement. He's been diagnosed with his current episode of 1 year, and he hasn't tried any other systemic treatments. And then finally, there's Maria, who is still unmanaged. She's struggled for several years. She was diagnosed with alopecia areata 7 years ago. Her current episode of hair loss has lasted 2.5 years. She's tried some prior systemic treatments. That gives you an idea of the variety of different patients who you would consider for low treatment. So now let's take a look at the clinical trials. It was quite exciting to be part of this clinical trial. This is the fun part of being in being an investigator in clinical trials, is that when the patient starts in the study, you don't know if the patient is active drug or placebo, but it's fun to watch the patient as you follow them starting from day one. So we were always very curious at what point patients would grow their hair and how quickly. You'll see here that the primary endpoint was measured at week 24. Again, the definition of severe alopecia areata in the Allegro 2B3 trials was 50% or more scalp hair loss involvement due to alopecia areata. And then they followed patients out to week 48. So here is a brief review of the Severity Alopecia Areata tool. So something important to remember is usually we think of 100% as something good, like I got 100% on my test score. But when we're talking about hair loss, this is actually thinking slightly the opposite. So a SALT 100 means you have complete hair loss. And you're wanting to go for a SALT 0, which is no hair loss. You'll also see highlighted at the bottom here, a SALT 20 means 80% regrowth and less than 20% hair loss. So we also looked at eyebrow and eyelash involvement. So that is something also to consider when you're evaluating the severity of alopecia areata. So it's not only the surface area involvement of your scalp, but also whether you have eyebrow and eyelash involvement. Here are some of the key inclusion, exclusion criteria. One I want to highlight is that the patients could not have had any evidence of regrowth within the last 6 months before starting the medication, and their current episode of hair loss had to be less than 10 years. As we know, patients with alopecia areata can have episodes of growth and loss. They could have had the diagnosis of more than 10 years, but their current episode was less than 10 years. So meaning they've had an episode of regrowth in the past. Other key exclusion criteria, no prior use of any JAK inhibitors, and then you can see no other history of herpes zoster. We know JAKs can have a signal with shingles. Let's take a look at the baseline criteria of these patients. So JAK inhibitors are really the first approved systemic treatment specifically designed for alopecia areata. So there was a huge unmet need. In fact, at my clinical trial site, we had a list of patients waiting to get into the study. So what you'll see here is that the severity of alopecia areata is on the very high end, meaning if you look at this average SALT score, it was 90%. That's 90% hair loss. In fact, almost half of patients had totalis or universalis, though, and you can see that was 46%. The average duration of alopecia areata since diagnosis was almost 7 years. You'll also see on the left-hand side that there were about 15% adolescent patients, even those 3% of patients who were greater than or equal to 65 years old. Slightly more female patients were in the trials, and these trials were conducted globally, so you can see there were quite a few Asian patients as well as Black patients. Okay, so let's take a look at the clinical efficacy, and this was the exciting part. The clinical trial was actually being conducted through the COVID pandemic, and what was so impressive, as I was explaining before, that there were many patients who wanted to be in the clinical trial, is that as the pandemic was evolving, these patients still came to clinic and wanted to get their drug. And that just shows you how much it meant for them to regrow their hair. So let's take a look at the primary endpoint here. This was measured at week 24. So you can see that here, 23% of patients achieved a SALT score of less than or equal to 20, or 80% regrowth. So at first you might not feel like that number is exciting, but when you watch to see how these patients evolve and give this medication a little more time, we're going to see that more patients will grow hair. And that 6 months is too early to evaluate efficacy. So don't give up. That's my message. And so you see that as patients continue out to week 48, taking Litfulo 50 milligrams once daily, we now have 43% of patients, almost half of patients, achieving a SALT score of less than or equal to 20. So when I'm talking to my patients about taking the medication, I tell them I really want them to take it for at least 1 year. Let's take a look at some of the images from the patients from the trials. You can see here, we see at baseline, this is a 36-year-old female taking the medication, and at week 12, you can already see some of those vellus hairs, and sometimes I call them peach fuzz, and that's what patients call them, and you know the patient is on their way to regrowth. This patient had quite a robust response. By week 24, really nice mature hairs. Here's an adolescent 16-year-old boy who has toe talus, and you can see by week 12 it's really hard to see if there's any growth. In fact, it's hard to photograph these fine little baby hairs, the vellus hairs, but by week 24 you can see he has very nice mature hairs. Okay, let's take a moment and look at eyebrow and eyelash involvement. So how often does alopecia areata affect eyebrows and eyelashes in your patients? So previously, if you were looking at the demographics from the Allegro trials, you'll actually see more than 75% of patients had eyebrow or eyelash involvement. So here we look at the response for eyebrows and eyelashes at week 24 and week 48. And what you see here is that, again, with more time, we see that around 40% of patients are having improvement in their eyebrow and eyelash involvement. And in fact, it was something that when I firsthand saw these patients respond with regrowth, sometimes it was scalp regrowth first, other times you would see a response in eyebrows or eyelashes first. Here's some images from the research patients. You can see really nice regrowth of eyebrows and eyelashes at week 24. And then in the final section, we're going to cover safety. I think this is one of the most important questions that many of our patients ask us is, what about the safety? So here are the box warnings. Now, in my clinic, when I'm talking to patients about this and explaining, we talk about, we decide on therapy, and the next step is we have to talk to them about these box warnings. So it may sound something like, the medicine that I'm going to be giving you comes with some 4 scary warnings. And I say that ahead of time so that patients aren't looking at me like, you're crazy, Dr. Soung. And I say, this medicine comes with 4 scary warnings that came from a different medicine within the same class that was used for rheumatoid arthritis. So that gives them a little bit history that this came from the oral surveillance study that was a post-marketing study looking at rheumatoid arthritis patients who had cardiovascular risk factors or risk factors for a heart attack that were 50 and older. In fact, we have now 2 years of safety data with Litfulo, and it does not appear to have the same risks as what we saw with the patients with rheumatoid arthritis. My goal is that I want you to tell me if you're having any side effects, and I'm going to be monitoring you closely. And this is a partnership so that the patient knows that I am aware of these side effects and I'm going to be monitoring them. So that's how the conversation sounds when I'm talking to my patients about Litfulo. Most of my patients are pretty excited that there is finally a treatment that specifically addresses the inflammation in alopecia areata. So often they're overjoyed to start a medication that was designed and gives acknowledgement that alopecia areata is a true medical condition. Now, moving on to safety, here we're also going to show you the safety, where the safety data came from. So in fact, The safety data comes from, you can see here, 3 of the placebo-controlled trials, and then these patients went into the Allegro long-term study. So that was over 1,600 Litfulo-treated patients, representing over 2,000 patient years. More than 1,000 patients had more than 1 year of exposure. I also said that the study is ongoing for 3 years, so we'll continue to have more safety data as patients finish. Anytime we're looking at adverse events that are observed in clinical trials, there are limitations and biases. So let's first start with what's most common in the first 24 weeks. And this is exactly what I saw firsthand in my patients. Headache, diarrhea, and acne were the most common. So we know that there is a signal for acne in JAK inhibitors. I would say that diarrhea and headache were often mild to moderate and did not lead to discontinuation. Here are some specific adverse events of interest reflected in those from the boxed warnings that we would be watching more carefully. I did mention shingles or herpes zoster is more common in JAK inhibitors. In my personal practice, I do not require that my patients have the shingles vaccine, but I do offer it. You can also see that when we look at these events that we're worried about that came from the oral surveillance study, we're seeing very low numbers, 0 or 1. There is a little bit of urticaria. In my firsthand experience, often easily resolved with an oral antihistamine. Here are lab abnormalities that we will be watching for. In terms of the actual events or abnormal abnormal labs, you can see here, these were very rare events. So a lymphocyte count of less than 100 only occurred in 1 patient, and age appeared to be a risk factor. It was uncommon to have any platelet decrease of less than 100. You can also see there was no subject with a platelet count of less than 75, only 1 subject with a platelet count of less than 100. CPK was also evaluated and monitored for in the patients. There was only 2 subjects within the first 24 weeks, and then some patients with liver abnormalities. And we'll also take a look at how to initiate a patient and what labs to monitor for Litfulo. Okay, so that brings me to my next section, and let's start by reviewing the dosing. So it's 50 milligrams, 1 pill once a day. There's no titration of the medication. So it can be taken with or without food. The capsule should be swallowed whole, and if patients forget, they should try to take the dose as soon as they remember, but then if it's less than 8 hours, they should just resume their regular schedule. Other considerations for patients. So this is kind of those situations where you would not recommend a patient starting. So if they have an active infection like hepatitis B or C or TB, any risk for thrombosis, platelet count of less than 100, a lymphocyte count of less than 500. Otherwise, most of our alopecia areata patients are generally healthy because they're young, in their 20s to 30s. And you can see the package insert does show certain situations where you would consider the risks and benefits. But what we want to get to is, well, now you and your patient have made a decision to start Litfulo for their alopecia. What tests would you screen for on initiation, and what are you going to monitor for afterwards? So let's look at the first light green column, which is before initiation. So you want to screen for any sort of chronic infection. That includes a TB test and your hepatitis B and C lab tests. And then next, we're going to look for our CBC, and then your chemistry panel, including your liver function tests, and then checking to see if your patient wants any of their immunizations. Now, according to the package insert, for monitoring, the only required lab is your CBC 4 weeks after initiation in order to check to make sure the patient doesn't have any decrease in their platelet count. After that, the package insert states it's based on your expertise and in terms of how often you want to monitor. In my personal practice, I check at 3 months because that's when I'm going to bring the patient back if they feel like they just kind of want to check in to see if they're having any side effects. Otherwise, and then after that, it's every 6 months. It really takes time to grow hair, so I always tell patients, again, you're going to be on this medicine for a year. Here are some additional considerations that you can refer to the package insert. It tells you when you would interrupt a dose because of a lab abnormality or discontinue. Again, we already reviewed what the most common lab abnormalities were, so this is usually not a problem. In terms of vaccinations, just remember no live vaccines. This medicine has not been studied in pregnant or lactating women, so not recommended. And I always remember to have a discussion with my women of childbearing potential in terms of what they want to do with contraception. I don't require it, but it's good to have a discussion. Okay, so again, let's kind of review what patient is systemic ready for Litfulo. I gave you 3 examples before, and I also want to add to that. You know, we talk a lot about here because the clinical trial was designed with severe being 50% or more of the scalp surface area involvement, but other things to consider according to and we know in dermatology, we don't just look at the surface area, but we take a multifactorial approach. So that means considering whether the patient has eyebrow or eyelash involvement, their response to topical therapy or intralesional therapy, as well as the impact on their mental health, and finally, whether it's rapidly progressing. So in my personal practice, I take all of these things into account when I assess whether they're mild, moderate, or severe. And it's not simply just a scalp surface area number. Okay, so Pfizer has a great access and reimbursement support program for Litfulo. In certain places, you know, I would say in California, in my region, about 60 to 70% of insurance companies are now recognizing that alopecia areata is a medical condition and a covered benefit. And so in those situations where it isn't, as long as you appeal it, and the patient has a commercially insured insurance, they can get access through the Pfizer program. Okay, so let's wrap up with the key takeaways. I'm excited for you to try Litfulo. So this is the first and only FDA-approved treatment for severe alopecia areata in both adults and adolescents as young as 12 years old. Remember, this is a little different from your other JAK inhibitors that you are familiar with. It's a kinase inhibitor because it inhibits JAK3 and a new family of kinases or enzymes called TEC kinase family that is also involved in inflammation. We looked at the primary endpoint, which was 80% regrowth or a SALT score of less than or equal to 20 at 24 weeks. And that is just the first time point. In my personal experience, that's not long enough to see hair growth. You saw that when we gave patients an additional 24 weeks at week 48, now we have more than 40% of patients achieving a SALT score of less than or equal to 20. We also reviewed the safety profiles for adults and adolescents. I'm looking forward to seeing the 3-year safety data hopefully soon. And then finally, the dosing is easy. So no titration or dose adjustments. It's just 50 milligrams, 1 pill once a day. So to wrap up, I hope that you've now learned about a new treatment to offer your alopecia areata patients and to give them hope. What Litfulo means to alopecia areata patients is finally recognition by the medical community that this is a real medical condition. Remember, for many years when we didn't have treatments, many patients were told that it's just their hair. Hair loss can be life-altering. So I can't wait until you get to tell me your stories about how your patients have responded. Helping patients grow hair is truly magical. So thank you so much for your time and attention today.
So remember, if you have any questions, please write them in the question chat pane on the right-hand side of your screen. And I wrote you a note there so that you know exactly where to write the questions. You can also send any questions to info@idefeducationalseries.com if you think of any questions after the webinar. So Dr. Kircik.
So Jennifer, thank you so much for that very nice lecture that we learned a lot about alopecia areata, right? Until now, we have this problem for a long time. We see those patients in our clinic. I myself, actually, when I was a kid, I did have alopecia areata. I was 6 years old. My mom used to schlep me to the dermatologist and get all these injections. I hated it. I didn't want it. So I know how it feels. Unfortunately, my problem has been solved now with androgenetic alopecia, right?
I didn't
It's one kind of treatment. So what I want to ask you is, first of all, since it's a new thing for us, and you did mention it, but to clarify, what does severe alopecia areata means? How do you define it?
Yeah, great question. I think this is an important concept to review because I get questions all the time from colleagues is, I have a patient who has totalis. Is that considered severe, or would they be a candidate? Is that too severe? Or I have a patient who has multiple patches and is rapidly progressing. So I like to refer to the alopecia areata severity tool. It is a tool defined by a group of alopecia experts, and the publication is out there that you can refer to. So it's a multi-dimensional tool that takes into account first surface area and then 5 other factors. So surface area is anything greater than 25% involvement is considered moderate, 50% and above is severe. Now, if you have an extra criteria that I will tell you of the 5, then you can bump up 1 level. So, for example, if you have significant psychosocial impact, that'll bump you up 1 level from mild to moderate or moderate to severe. If you had rapidly progressive hair loss, if you've tried topicals and intralesionals, and then finally, if you have eyebrow and or eyelash involvement, that can upgrade you from one category to the next. So again, that really emphasizes that it's not just the surface area that defines severity, it's a multi-dimensional tool.
That's good to know. You know, it's not only the surface area, but the other factors. It's almost like when it comes to psoriasis, right? We think about the difficult area. What's the youngest age you can give this medication?
Well, right now it's FDA approved in 12 and older. So that's what the label
Perfect.
is. We'll see if it's going to be studied.
Let's say on the label. Is Lutfilo available for alopecia universalis patients?
Absolutely, right? So you saw in the data that I presented to you from the Allegro 2B3 studies that almost half of patients had totalis or universalis. So absolutely. I think this is the first time these patients who have complete hair loss with or without eyebrow and eyelash involvement have a real chance of growing hair.
So, you know, when it comes to atopic derm, JAK inhibitors, they have some step therapy. They have to skip this, that. What's the deal with alopecia areata when it comes to Lutfilo? Do the patients have to fail something? Do they have to have a prior treatment?
Well, you know, in my personal practice, any patient who has more than 50% of the scalp, I'm not sure it's really pleasant to be doing intralesionals all over the scalp. Leanne, you just shared your firsthand experience. Now, whether insurers require that might be a slightly different story. So I've seen some insurers say you have to try topicals and intralesionals in order to qualify. So I think it's very insurance or regionally dependent, but that's not something that I personally require. I think many of us who do treat patients who have more extensive involvement in the scalp often see that really intralesionals are not working in those situations.
Anything particular in the label?
What do you mean by that question? Is that
the label? There anything, you know, for atopic derm, for example, they say that you have to fail the topicals, blah, 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 or some biologics. It's not necessary for Lutfilo, for alopecia areata label.
So nothing in the label that says that you have to try and fail anything.
Perfect, perfect. Now, we know that alopecia areata is a difficult disease to treat, right? It reminds me of vitiligo, and we have experience from the topicals in vitiligo. It does take a long time for the JAKs to kick in. You know, the studies are done for 6 months, and then we see better results over 12 months. But how early do you see SALT 20 results compared to the placebo?
Right. So if you'll remember, the primary endpoint was measured at week 24. And we see at that time point about 20% of patients, a little more than 20% of patients achieving 80% regrowth. Again, that what you see is that giving another 6 months later at week 48, that now over 40% of patients are achieving 80% regrowth. So we're seeing that at week 24 that hasn't peaked yet. And really, I tell patients that you want to give it at least a year.
Yeah, I really think that this disease state takes a lot of hand holding, right? When the patient comes back in 3 months and you ask them, how are you doing? They say, yeah, a little bit better, but not much. So I think at that point, you have to make sure that they stay the course and they don't give up, because it's not the same as atopic derm or psoriasis, where you see really early onset and a lot of early results.
Yeah, and you know, honestly, I've actually seen many patients. My patients have surprised me. I've had patients come back at 3 months for more of a safety check, and like that hand holding to support them. And some start to get those the peach fuzz and vellus hairs, and they are thrilled because they've never had hair before, or they can't remember the last time they've had hair. I even had one young gentleman who's 21. This was the first time he grew arm hair. And he said that this was the first time he felt like a man because he's never had hair on his body.
Yeah, it's really impressive and it's great. I mean, you know, it's the first time we can give hope to our patients with alopecia areata that there's something that really works. Well, on that note, I think we are done with the questions, and I thank you very much, Jennifer. I appreciate that eye-opening lecture, but I also want to thank our supporter, Pfizer, tonight, to make this program available to our audience. So now that we are done with the Pfizer program, I can invite you for tomorrow night, for Thursday night, to a very interesting lecture where we're gonna hear from Dr. Mona Shariari, raising the bar, exploring higher level endpoints from a head-to-head study in the treatment of moderate to severe atopic dermatitis. And I'm very happy to announce that one of our rising stars in dermatology, Dr. Ali Shahbaz, is gonna moderate this session. Unfortunately, I'm gonna be on the road. So I thank you so much for joining us and have a good evening. Bye-bye.
Good night, everybody.
Night.